The standard method for prophylaxing against graft-versus-host disease using either a matched sibling or a matched unrelated donor is to use a combination of a calcineurin inhibitor, usually tacrolimus, sometimes cyclosporin, in combination with methotrexate, which is a cytotoxic agent that's actually given to the recipient a few days after the transplant. Most regimens give it on days 1, 3, 6, and 11 after transplant. Some it's just days 1, 3, and 6. An alternative that was investigated in coming up with an aggregate grade. That grading scheme goes from grade 0, which means no GVHD, through grades 1, 2, 3, and 4. Grade 4 being the most severe and the life-threatening acute graft-versus-host disease. When patients have grade 1 or mild graft-versus-host disease, that typically is going to manifest as a localized skin rash, and we will frequently use topical steroids to treat that. For patients that had steroid refractory or dependent grade 2 through 4 acute GVHD. On the study, about 70 patients were ultimately treated with ruxolitinib for steroid refractory GVHD. About 50 were evaluable based on the FDA analysis that led to the approval. And in that analysis, it was found that by 28 days after the initiation of ruxolitinib, the overall response rate was about 55%, with about 30% complete response rate. And the best overall response rate was over 70%, with a roughly 50% complete response rate as the best response seen on ruxolitinib. So this appropriately led to approval of the agent based on this relatively small number of patients. But because there are no other agents that are FDA approved for acute GVHD, this is definitely an advance for the field. And as I mentioned earlier, the field had already started using ruxolitinib off-label because of its efficacy, and now we have it available because of the publication of the REACH-1 study. This study is going to be confirmed in what's called the REACH-2 study, which is actually randomizing patients with steroid refractory or dependent acute GVHD between ruxolitinib or best available care based on what their provider thinks the patient should receive. This study is actively accruing right now around the world, and it is expected to have some data available perhaps in 2020. And hopefully we'll see that ruxolitinib's efficacy is borne out in that randomized study.